We are live.
A very good evening, everyone. I am Dr. Piyush Bansal, Chairman of the Scientific Committee of Maharashtra Ophthalmological Society, and I welcome all of you to a fantastic session of case presentations today focusing on cornea. And we have some excellent cases. The first one is going to be presented by Dr. Shraddha Singh, who's a junior resident at Bairamji Jijaboy Government Medical College and Sassoon General Hospitals in Pune, and she's going to be ably mentored by my dear friend, Associate Professor in BJMC, Professor Satish Chitoe. We have another case which is going to be presented by Dr. Mrunal Gogre, who's a junior resident at Hindu Hriday Samrat Bala Sahib Thackeray Medical College and Cooper Hospital in Mumbai. Her mentors in this particular case are Dr. Amrita Ajani, who's additional professor, as well as additional professor and head of department, my dear friend Dr. Charuta Manke, again, of course, from Cooper Hospital in Mumbai. Now, besides their presentation, our examiners are going to be two prolific corneal surgeons, both my senior alumni from LV Prasad Eye Institute. Our national examiner is Dr. Swati Tomar, very accomplished corneal surgeon from Soranetra Eye Hospital in Jaipur, who's also been associated with the medical college.
Mrunal, can you please mute yourself? Mrunal? Sunilji, you have to mute her.
So we are extremely honored and happy that Dr. Swati Tomar could take some time out and be our external national examiner. And may I also welcome Dr. Parul Deshpande, our own corneal surgeon from Mumbai, from Sarvodaya Eye Hospital. She needs no introduction in Maharashtra at least, and a prolific corneal surgeon, excellent teacher. So yes. I welcome you.
Am I audible to them? Because I'm not able to hear.
And I would also request now the member of the scientific committee, Professor.
I don't know about my audibility, but I do know that I'm not able to hear them.
Sunilji, can you just mute Mrunal, please?
Okay. Huh?
So I request Dr. Archana Vare to please take over the presentation, take over the program now, explain the rule, and proceed with the program, please.
Okay. Thank you, Dr. Piyush. Sunilji, can you mute Dr. Mrunal, please? Charuta, can you ask her to mute herself?
Can you just tell me how to share the screen also?
Sunilji, are you there? Is somebody from Zadneotech there over here?
There's nobody.
Can we have?
Can you please mute Mrunal?
Yourself.
Yes, ma'am.
Make Dr. Archana Vare the co-host, or maybe the co-host, and please mute Mrunal.
And
yes,
Mrunal, Dr. Shraddha will be presenting her case first.
I muted. Dr. Mrunal, can you just stop sharing, please?
All right. So please stop sharing, and please let only Dr. Archana Vare speaks now.
Yeah. So thank you, Dr. Piyush. Good evening, everybody. So today we are discussing two cases of cornea, and the first case will be presented by Dr. Shraddha, and her case presentation, she'll be presenting her case in 8 to 10 minutes, and then the examiners, they'll be asking her questions for next 20 minutes, and at 8:30 we'll start with the next case presentation, and we will follow the same format for the next presenter. So I request Dr. Shraddha to start sharing her screen and present her case, please.
Ma'am, should I start?
Yes, please start.
Good evening, everyone. I'm Dr. Shraddha Singh, a third-year junior resident from BJGMC, Pune. My mentor for today is Dr. Satish Chitoe, sir, an associate professor at BJGMC. Today, I'll be presenting a case of a 25-year-old male driver from Pune who came to the ophthalmology OPD for his regular post-operative follow-up. He was apparently all right 15 years ago when he started experiencing diminution of vision with associated with a whitish opacity in the left eye, which was gradual in onset, painless and progressive in nature, which later stayed persistent. For the same complaints, he underwent left eye corneal transplant surgery with IOL implantation. The patient is currently post-operative day 30 and has come for regular follow-up. There was history of blunt ocular trauma to the left eye while playing 20 years ago. There's history of left eye corneal transplant surgery with IOL implantation 1 month ago. There was no history of spectacle use, purulent discharge, recurrent redness and pain, blisters around the eye, chemical or thermal injury, sudden decrease in the vision, redness, pain, photophobia, foreign body sensation, watering or irritation, pain, discharge, whitish discoloration of the graft post-operatively, headache, eye ache, vomiting, halos around the eye, history of ocular trauma or eye rubbing post-operatively, or any history of missing medications or non-compliance to medication. There is no history of major systemic illness, and the patient is currently on oral steroids and topical medications as advised post-operatively. The personal and the family history were within normal limits, and the general examination and the systemic examination was within normal limits. The ocular examination, the head posture was normal, ocular position was normal, and extraocular movements were full, free, and painless in all gazes. First, I'll be describing the right eye. The visual acuity in the right eye as measured on Snellen's chart was 6.6. The near vision was N6. IOP measured by NCT at 11 a.m. was 14.7 millimeters of Hg of mercury. Lid and adnexa were normal. Conjunctiva was normal. Cornea was clear. Anterior chamber was normal in depth and had clear contents. Iris, the color pattern was normal. Pupil was normal in size and reactive to light, and the lens was clear. In the left eye, the visual acuity as measured on Snellen's chart was 636, which was not improving with refraction. The near vision was N8. The IOP measured by NCT at 11 a.m. was 12.5 millimeters of Hg. Lid was normal. In the conjunctiva, there was a mild congestion present nasally. There was a full in the cornea. There was a full thickness penetrating keratoplasty graft of size 7 by 7 mm, circular, which was slightly eccentric inferonasally. It was clear with intact epithelium and uniform stromal thickness. The graft host junction was well opposed with 16 interrupted sutures intact with the knots buried. The anterior chamber was well formed and quiet. Iris, the color pattern was normal, and there was a presence of surgical iridectomy at 7 o'clock with iris atrophy superiorly to the peripheral iridectomy. The pupil was normal in size and reactive to light. The lens state the patient was pseudophakic, and there was a few iris pigments on the IOL, and there was presence of peripheral posterior capsular opacification. This is the slit lamp picture of the patient of the right eye and the left eye. The fundus of both the eyes were normal. The media were clear. The disc, the CD ratio was 0.3. Blood vessels were normal, and the foveal reflex was present. So my provisional diagnosis is right eye within normal limits and left eye status post optical penetrating keratoplasty with peripheral iridectomy and pseudophakia.
Thank you, Dr. Shraddha, for a wonderful presentation. And I request you to stop sharing your screen, please.
Yes,
and I request Dr. Swati ma'am to ask questions to Dr. Shraddha.
Arshana, if you can keep the photograph of the keratoplasty eye on the screen, that would be great.
Yeah, Shraddha.
To ask her the question. Yeah.
Shraddha?
Yes, ma'am.
Start sharing your screen again and put that photograph. Yep.
Yeah, Shraddha. Hi, everyone. So, Shraddha, you presented well. So, just a couple of things to make clear. So, this injury that you say, he was a 25-year-old, right? So, and had an injury 20 years back.
Yes, ma'am. 15 years ago when he was a child.
So do you think you have to, and the vision right now is how much best corrected? 636.
Ma'am.
Right. So when you look at the diagnosis, so do you think, are you missing something else in the diagnosis also, or maybe it's with such a beautiful graft and such clear cornea, with no improvement in vision, what could be the causes of low vision not improving?
Patient could have developed amblyopia.
Yeah, so yeah, could have developed amblyopia also. But do you think would have developed or at
Ma'am,
5 years of age with or had amblyopia?
ma'am, the patient has amblyopia.
Did you look into the fundus also?
Yes, ma'am.
So post keratoplasty, did you look into the fundus? So it was okay?
Yes, ma'am, the fundus was normal.
Also, did you do a B scan before surgery?
Pre-operatively, the B scan was done, ma'am. The B scan was also normal, ma'am.
Okay. Okay. So would you like to revise your diagnosis before surgery and after surgery?
Before surgery, the patient had leukomatous corneal opacity
With
amblyopia.
Okay. So when you have this kind of an opacity developing at 5 years of age, so what else can you should look for in a patient at such a young age, at till the age of 25 years when he got operated, like after 20 years, what else could have happened with such severe amblyopia?
Shraddha, do you have a picture with both eyes?
Pre-operative picture, ma'am.
Yeah.
No, ma'am.
Okay.
So was the opacity involving the axis, visual axis totally?
Yes, ma'am.
Okay. Right. Okay. So what would you also do to now, since he's 30 days of post-surgery and with such a nice graft? So what is your post-op regime, that after 30 days is what you follow after keratoplasty?
Ma'am, we'll take regular follow-up of the patient and we'll make sure the patient is putting the topical drops. Patient was started on steroids immediately in the post-operative period, ma'am. And we'll look for any signs of graft rejection.
So do you think at 30, so what is primary graft failure? Are you looking at primary graft failure or are you looking at a very early
Can I
rejection?
ask her to stop sharing her screen so that
Yeah.
Now, Shraddha, you can stop sharing your screen.
Yeah, Shraddha.
Yes, ma'am.
So what is it on treatment right now?
Ma'am is currently on topical 1% prednisolone acetate and
How many
antibiotics.
times?
4 times, ma'am.
4 times. Okay. And what else?
And moxifloxacin, eye drop moxifloxacin 0.5%, ma'am, putting for 4 times.
And anything else that he's putting?
Has been tapered, ma'am. He has stopped putting. He stopped taking oral steroids.
Okay. So what is your normal post-op regime after 30 days of keratoplasty? So
Ma'am,
how long are you going to, give, like what would be your steroid frequency and how are you going to follow up this patient?
Ma'am, corticosteroids are the first line therapy. So it can be given. We can give topical steroids. Prednisolone acetate 1% suspension can be given, and usually the steroids are given for as long as possible to avoid any to avoid rejection, ma'am. And in the post-operative,
How are you going to taper or you are going to keep it 4 times a day?
yes, ma'am, will be tapering, ma'am.
What is the normal regime that you follow if everything goes well with this patient? So how would you tell the patient how do you taper? Then what are the frequency of the visits normally?
Ma'am, initially the patient is called in the post-operative day 1 for follow-up. Then the patient is called on operative day 3. Then patient is called on post-operative day 7. It's called after 2 weeks, and then after a month, and then the patient can be called 1 monthly for follow-up, ma'am.
Till when?
Till 6 months, ma'am.
Okay. So, okay. And how would your steroids go? Like after now, like four times is what he's taking now. So how do you plan to taper the steroids, or at what steroid concentration would you like to keep, like frequency?
After 1 month, ma'am.
Yes. Not from now on.
Uh,
It's okay.
Ma'am, generally, after 1 month, we can ask him to put the drop 3 to 4 times a day for a month, and then we can gradually taper it for the next 2 to 3 months. He can put it twice a day, and then for the till 4 to 6 months, he can put it for 1 year, and then till the 1 year is complete, he can continue putting the oral topical steroids for 1 time a day, ma'am.
Parul, would you like to ask anything?
Yeah, so Shraddha, you just said that the post-operative steroids, you started it as 4 times a day, and
Yes, ma'am.
what you said was a random tapering of the medication. So normally, when we look at a post-operative medications, we usually say every 2 months, you reduce 1 drop at a time. So I wanted to know, at the end of 1 year, would you still continue your topical steroids? Or you would
Ma'am,
stop?
as the drops can be stopped, but then the graft rejection can, ma'am, the graft rejection can occur anytime, ma'am. So the patient can be putting the topical steroid for 1 time a day, at least.
Yeah, so you would continue it for probably a much longer period in this patient, right? Now, do you know what was the diagnosis for this patient, preoperative? What is your
Ma'am,
likely diagnosis in this patient?
ma'am, the diagnosis was a central avascular corneal leukomatous opacity, ma'am.
You said the patient had recurrent redness and inflammation, right?
No, ma'am,
In
there was
this
no history.
previously.
No, ma'am, there was no history of recurrent redness.
Okay. So this was in-house done keratoplasty, or
Yes,
it was
ma'am.
done somewhere?
It
Yeah. So
was
do you have any tissue report? Do you get a biopsy done of the corneal button to find out whether this patient had any previous viral etiology?
no, ma'am, we do not have it.
So ideally, suppose if I see a child with a central leukoma, and there is no significant history, and you want to know what is the reason that this patient has had this leukomatous opacity. There can be one single isolated infection somewhere in the past, and that's why he got this scar. And the second possibility is that the patient could have had a viral infection. So you sometimes need to do the half corneal button biopsy and the viral studies. So you could see probably lymphocytes and this thing in the half corneal button, suggesting that this patient may have a viral infection. So in the post-operative period, sometimes these patients, if they develop a viral recurrence, you can give them antiviral therapy. So a patient with a leukomatous opacity, I think this one thing you need to look at. Second thing is that you said that the vision was only 636. The graph looked very clear actually at the end of 1 month. I'm very happy that the graph was really, really very well done surgery. So did you look at the keratometry and the astigmatism? Because you said it's amblyopia. So what was the keratometric values on a normal keratometer also actually? So did you think that there was a high astigmatism and that could have been the reason for his vision to be low?
Ma'am, there could be chances, but I did not check it, ma'am, post-operatively.
So what do you
Okay.
think what could be the reason for decreased vision? 636 is very less vision looking at the graft, you know. At least with pinhole, he should improve to about 612, we can imagine. So it's very important that, you know, you look at the keratometry also and probably try and do a pinhole and see that, you know, if he's improving, and if it's not, then why? So suppose, Shraddha, 6 months down the line, you give the best corrected vision and still the patient has vision of 636. So how would you convince the patient, or what would you tell the patient that why his vision is not improving, and what else can you do with this after 6 months?
Ma'am, after 6 months, we can plan for suture removal, ma'am, selective suture removal in view of astigmatism.
How
So
early
if
can you
this,
start?
yeah, how early can you
How
start?
early?
Ma'am, if the sutures are tight, uh,
How would you know the suture is tight? What can you do to know which suture is tight in your clinic?
uh,
How would you assess which suture to remove?
Ma'am, slit lamp examination, in slit lamp examination, we'll find that there can be pulling of the graft near the suture, ma'am. There can be presence of radial striae, or there can be a flattening of the graft. And uh, by doing keratometry, we can find the steep meridian, and the tight sutures usually lie along the steep meridian.
What else can you do except for, you know, seeing on slit lamp, also on like a retinoscopy, or anything else that you can do?
Ma'am, if we stain the patient, there can be pooling of dye over there.
And any diagnostic, you know, technique we can use to find out which is the steeper meridian, which is the flatter one, how many sutures we have to remove, one or two?
Ma'am, using corneal topography,
Right.
pentacam, ma'am.
Yeah, so we can at least use a corneal topographer. So one suture would reduce how much astigmatism, Shraddha? So depending on, yeah, so depending on the tightness, 1.5 diopters to 2 diopters is what one suture can do. And we can also, on the other side, diagonally opposite, we can, you know, combine with the other suture removal also. So what precaution do you take when you remove the suture in, like you remove the suture today, like you remove 2 sutures. So do you change your medication, and why?
Ma'am, whenever we remove the suture, it's like creating a wound over there. So it's important that we prevent further infection. So whenever there is an intervention like suture removal done, we are supposed to continue steroids. Uh, Even we can increase the dose of steroids, ma'am, for a short duration of time.
So we increase the
Push up.
duration of steroids and we give antibiotics also. So why we increase the steroids? Because infection can be dealt with an antibiotic. Okay, so it may incite a rejection, you know. So we increase the steroids to prevent it, because it's kind of a trauma when we remove the suture. So the antibiotics would help in the healing, and this can, okay.
Shraddha, two questions to you. One is how early can you start doing a selective suture removal? And what are the other indications of removing stitches in a graft, in a full thickness graft? When would you go and electively go and remove? Okay, now I have to remove the stitch. So what are the indications? And how
Ma'am,
early can you
usually,
start your selective suture removal? That you've not answered, yeah.
ma'am, usually whenever a tight suture is present, we can plan removing the suture after 6 months. But if at all a tight suture, it causes a formation of delin, we are supposed to remove it immediately, ma'am.
Okay, so selective suture removal, Shraddha, you can start as early as 3 months. Okay. Before that, you do not do it because the graft whose junction is not well healed. Okay. And can you plan it every 15 days, a selective suture removal, or every month? Or what is the time period that you usually keep between the two selective suture removals? So let's say today, if I do, how early can I do the second sitting of a selective suture removal?
Second sitting, after 3 months, ma'am.
So normally it's usually 2 months. Do you remove consecutive sutures, adjacent sutures, or you will never remove consecutive sutures?
Ma'am, consecutive sutures usually should not be removed because it can cause wound dehiscence, ma'am.
Yeah, and what are the other indications for your suture removal besides your astigmatism, selective suture removal that you do for astigmatism? What is the other indication?
If at all it is broken or loose, ma'am.
Or it's got infected, right? What else?
And
What else? Which can threaten your graft? That's very important.
you
So
know, it
what
can,
causes rejection?
rejection.
What causes rejection? Why rejection happens? What do you see along the sutures?
Ma'am, infiltrates can be present over there.
No, you see vascularization. So when you see vascularized sutures, you need to knock them off so that the vessels don't enter your graft and it doesn't cause a rejection. Right?
And also, Shraddha, one more thing. So when you are looking at like 8 months or 9 months, so what other things every follow-up you need to see except for, the tight sutures, and except for suture, what else do you have to see every visit? Like in a follow-up, the patient is on steroids, the patient.
Ma'am, visual acuity should be checked because the
Yes.
symptoms.
Other than visual acuity?
Graft evaluation should be done, ma'am. Slit lamp examination should be done for
And
graft clarity. Graft host junction should be checked. The thickness of the graft should be evaluated. Then
Now, in terms of steroid use that you're doing it,
IOP
what is
should
the one thing? Yeah, that is what we want.
how do you check the IOP in graft?
Ma'am, usually
Which is a better method to check the IOP, Which kind of tonometer would you
ma'am,
use?
non-contact tonometry is done, ma'am.
No, Shraddha, you usually you resort to tonopen. I think that is one of the better modality to give you a pressure, but the availability of tonopen is not there everywhere. So the second most probably common that we use is application tonometry, not the non-contact tonometry. And there also, if you have, let's say, a tight meridian, two tight meridians, so you can take the pressures in the two meridians. So if you see the two prisms, biprisms, right? So the bifurcating point, you can keep in the tight this thing, and you can keep it in a loose, in the flatter meridian. And then you take the average of the pressure. Suppose if this patient develops a steroid response glaucoma, what are you going to do? How are you going to manage it? Let's say in 4 months down the line, the graft is clear, the patient has high pressure. So now what are you going to do?
In what, ma'am, after 4 months?
Suppose if the patient develops steroid-induced glaucoma, patient is having a high pressure. Possibility, obviously, that patient's looking at the surgical outcome, it looks as if the graft, there are no synechia, everything is looking good. So possible reason could be steroid, right? So if you
But we
find
can't,
that possible reason is a steroid-induced glaucoma, how are you going to manage it in a graft patient?
Yes, ma'am, we cannot stop steroids, so we can consider switching to weaker steroids, ma'am, and anti-glaucoma medications can be started for the patient.
So at 4
Which
months,
is,
will you suddenly? Sorry, Swati, go ahead.
yeah. No. Continue, Parul. Yeah.
So which? I'm sorry, I forgot what I have. At
So,
4 months, will
like
you
4 months.
suddenly switch off to the low dose this thing, steroid? Or you would continue simultaneously and first look at the pressure that has gone. So let's say if you are in 20s, you're not going to decrease the steroid. You're going to just add on one anti-glaucoma medication first.
Okay.
And then see whether it still can be managed, with your routine steroid drops. And if that's not happening, you will add another anti-glaucoma medications. And if then that time also, if you feel the pressures are not coming down, then probably you will start tapering your steroids.
Which is the low dose steroid that you're talking of, other than
Low dose steroids like loteprednolol, prednisolone, or fluorometholone can be used.
Yeah, I think it's time to move to our next case, but this was a very, very important
well done.
discussion.
Well done,
Yeah,
Shraddha.
and
You did very
yeah,
well. Yeah.
Shraddha, you did very well, but
Well.
you missed one important point to test the pinhole vision. Because in your MS exams, you have 6 cases and each case has 50 marks. But it is very important to check the visual acuity, then to do a pinhole vision, and then do retinoscopy, and then tell us about the best corrected visual acuity. You cannot miss the important step of doing pinhole testing. And one more thing is you missed your diagnosis of PCO. uh, Patient had posterior capsular opacification, so you could have included that in your final diagnosis. Okay, but it's very, very well presented and you answered very well. So congratulations to you and congratulations to Dr. Satish Shitore, who's your mentor today. So congrats, Satish. And now we move on to our next case. The next case will be presented by Dr. Mrunal. And I hope the technical glitch has been solved. And I request Dr. Mrunal to start sharing her screen. And her mentors are Dr. Charuta and Dr. Amrita. Yeah. So
Am I visible, ma'am? My presentation is visible.
yeah. Your screen is visible and you're audible also. So start sharing. Start presenting your case.
Okay, ma'am. Good evening, ma'am. I'm Dr. Mrunal, junior resident Department of Ophthalmology, HPTMC Medical College and Aaron Cooper Hospital. I would like to thank everyone for the opportunity and sorry for the glitch from my side. 34-year-old female school teacher by occupation come to OPD with chief complaints of foreign body sensation in the right eye since 3 weeks and pain and excessive watering in the right eye since 1 year. History of present illness. Patient was apparently all right 3 weeks back when she developed foreign body sensations, which is gradually progressive and associated with severe pain and watering since 1 week in the right eye. There is no history of trauma, contact lens use, itching. There is no history of eye surgery, similar complaints in the past. The past history, the one episode of redness, watering, photophobia, discharge, and pricking sensations in the both eye, which is more in the right eye than left eye, associated with cold and fever, for which she prescribed few drops, but details are not known. There is no significant systemic history, drug history, family history, personal history. On examination, general examination, patient is conscious, cooperative, and well oriented to time, place, and person, and vitally stable. Systemic examination is assessed and is within normal. On local examination, patient is orthophoric, facial symmetry is present, and head position is normal. On ocular examination, I would like to go for right eye first. On right eye examination, lid and adnexa is normal. Extraocular muscle movements are full and free. Uncorrected visual acuity of the right eye is 618 on distance Snellen chart with near vision of N8, which is not improved with a pinhole, and the best corrected visual acuity is 612. As patient was not cooperative, photophobic for the pinhole examination. On the refraction, the distorted reflex is seen on the retinoscopy even after putting the parakin for the pain management and the photophobia. Intraocular pressure on the applanation tonometer of the right eye is 16 mm. Anterior segment examination on the slit lamp shows conjunctiva having conjunctival and circumcorneal congestion. Cornea, multiple gelatinous grayish-white strands. One end moves with the blink and other end attached to the corneal epithelium. Fluorescent stain positive and corneal sensations are normal. This is the video demonstration of the filaments movement over the corneal surface with the blink. On further examination, anterior chamber depth is deep with no cells and flare. Iris color pattern are normal. Pupil circular, reacting to light. Direct and consensual light reflex are present. Lens is clear. Tear film, adequate tear film height is present. Posterior examination of the right eye is within normal limit with 0.3 CDR. Healthy neuroretinal rim and foveal reflex is present. The left eye examination visual acuity of the left eye is 6.6 with near vision of N6 with no significant refractive
Is your left
error.
eye within normal limits, Mrunal?
Yes, ma'am. Yes, ma'am.
So
Anterior
can
segment
skip
and posterior
this.
segment.
Yeah,
Yes,
you
ma'am.
can say, huh.
So my provisional diagnosis of the patient is right eye filamentary keratitis, secondary to keratoconjunctivitis, and the left eye is within normal limit. Differential diagnosis could be a viral keratoconjunctivitis, neurotrophic keratopathy, and can also associated with the recurrent corneal erosions, thymus and superficial punctate keratopathy, and superior limbic keratoconjunctivitis. On treatment, we start on the first appearance of the clinical on evaluation. On treatment, we started patient on mechanical removal of the filaments with the forceps under topical anesthesia. Then we start patient on preservative-free lubricating drops, eye drops, sodium hyaluronate 4 times a day, and mucolytic agent of N-acetylcysteine 10%, which is commercially not available. So we made the preparation with injection on N-acetylcysteine 20% and started on the QID doses. And for the pain management, we start patient on the eye drop pomade HS. On subsequent follow-up on the day 3, a slit lamp picture showing there is still the circumcorneal congestion and the circumcorneal congestion and conjunctival congestion. So we started patient on topical steroid, hydroxychloroquine 0.5%, 4 times a day in a weekly tapering manner. And on subsequent follow-up of the on day 10, patient is having clear cornea. Thank you, ma'am.
Yeah. So, will you please stop sharing your screen, Mrunal?
Yes, ma'am.
Yeah. And now I request Dr. Swati ma'am and Dr. Parul ma'am to ask questions to Dr. Mrunal.
So
Should I start?
Mrunal, yeah,
Start, Swati. Start.
yeah, start. So Mrunal, very
Okay.
nicely presented and very well, good pictures and good video taken. So I wanted to ask you, so what are these filaments and how they are formed?
Ma'am, basically filaments are the due to the corneal damage to the epithelium or the basement layer of the epithelium. The damage leads to with the attachment of the mucus and cellular debris due to the tear film instability or the underlying inflammation leads to the filament formation with help of microtoma causing the eyelids. The shearing force of the eyelids helps to form the filaments with the associated factors.
Okay.
Basically, you have central core of corneal epithelium, followed
Yes,
by
ma'am.
you have the peripheral conjunctival epithelium along with mucin, right?
Mucin.
That
Yes,
forms
ma'am.
that forms a filament.
Filaments.
Yeah. So, Mrunal, you said that the first line of treatment that you started was lubrication, right?
Yes,
So,
ma'am.
yeah. So, do you consider removing the filaments also?
Yes, ma'am.
And
Mechanical.
how do you remove
Mechanical.
these filaments?
Yes, ma'am. There are two methods can be done. First, we can remove with the non-tooth forceps, and second is the cellulose acetate paper. We can remove mechanically the filaments.
So what one thing that you should, always be very, particular about when you're removing the filaments? What precautions should you take, when you remove these filaments so that they don't recur?
Ma'am, the damage to the while removing surrounding cornea should not be damaged with while removing the
Cornea means
uh,
surrounding,
filaments
not
surrounding
the whole
cornea.
cornea. So surrounding cornea has how many layers? So which layer would you not like to damage when you're removing the
Basement
filaments?
Bowman's membrane, ma'am. The layer below the epithelium, the Bowman's epithelium. I should not able to damage it because that may lead to more filament formation.
Yeah. Okay. So did you investigate the patient systemically also?
Ma'am, on history taking only, the patient is systemically neat. So right, not evaluated the systemically, but on and
So
yes, ma'am.
what would you look for, systemically, what conditions could lead to filamentary keratitis?
Ma'am, there autoimmune conditions can also lead to the filamentary keratitis, thyroid disorders, which is superior limbic keratoconjunctivitis. The underlying cause can lead to the
So
filamentary keratitis.
which autoimmune disorders are you thinking about in this patient?
Ma'am, the autoimmune diseases like Sjogren's disease, rheumatoid arthritis, which can lead to severe dry eyes, and that can lead to the filamentary keratitis.
Okay. So did you investigate?
Uh, no, ma'am, because I was not suspecting Sjogren's. On the history. There is no history of dryness of mouth, and the tear film height is also adequate. So I have not gone through the systemic evaluation of the patient.
So what is your diagnosis? Why this is so severe in one eye, the other eye is normal?
Oh, ma'am, there is one history of there is one history of redness, photophobia, and foreign body sensation in the uh, 1 month back, which is more in the right eye and than the left eye. The more right eye is more involved. So could be that possibility of keratoconjunctivitis that leads to aqueous deficiency dry eye that can lead to filamentary keratitis in my patient, most probably.
Parul, you would like to ask something?
Yeah. So you said that there was some possible diagnosis that you looked at. So one of the first diagnoses you talked about was viral conjunctivitis. So which type of viral conjunctivitis? And if a patient with viral conjunctivitis develops filaments, what other signs would you see in these patients? So I want to ask that if a patient has a filament and you want to prove that this patient has a viral conjunctivitis, what other things would you see in the eye that will support the diagnosis of your viral conjunctivitis with the filaments and the corneal epithelial defect? Mrinal, did you understand the question?
Partially, yes, ma'am.
Yeah. So I want to know what will support the diagnosis of viral conjunctivitis in a patient who has filaments. What other signs would you see?
Ma'am, the most probable viral keratitis, the most probable sequelae of this epidemic keratoconjunctivitis can lead to this condition. And the signs we can see is the pseudomembrane formation, superficial punctate keratitis on the involvement of the cornea, or the sequelae of the viral keratoconjunctivitis.
Yes, so you are supposed to look at those things. So, because you said one of the first diagnoses was viral conjunctivitis. So, did you see all these signs in this patient? Not
Yes,
really.
ma'am.
Yeah, and
Yes.
this can be bilateral because if you see such severe variant of viral conjunctivitis, adenovirus, you will see it bilaterally happening here.
Bye. Yes, ma'am.
Now, what other signs that you looked for in ruling out a dry eye in this patient? You said you are not suspecting Sjogren's only based on the lower tier meniscus height. Can you say that this patient doesn't have a dry eye? what other things that you should have looked at on the ocular surface, which could have pointed to the diagnosis in the affected eye as well as in the unaffected eye?
Ma'am, the lead examination, meibomian gland examination, meibomian gland dysfunction can also lead to this dry eye condition. Then, uh, what else?
You should have looked at the tear breakup time in the other eye. You should have looked at the ocular surface staining
Okay.
of the
Staining.
conjunctiva in both the
Yes, ma'am.
eyes. This could have pointed to you that whether this patient has a dry eye. Are you dealing with Sjogren's? Because lower tier meniscus alone is not.
Mm.
Now, if you see so many of filaments and the tear meniscus, if you see, patient should have had an extreme amount of reflex tearing and the tear meniscus should have been doubled. So you
Yes,
cannot
ma'am.
rule out a dry eye in this patient, okay? So these are the other things that we should have looked at before you say that, okay, this patient does not have a diagnosis of dry eye, because the patient was 34 years old. You cannot rule out that this patient cannot have a rheumatoid arthritis or did not have an autoimmune disease.
Yes, ma'am.
Did you avert the
Yes.
lid, Mrinal? Did you avert the lid and see?
Yes, ma'am.
So what did you find on the lid?
There
It was
is no,
normal?
yes, ma'am, no follicles or a papillae are seen on the lid, on the everted lid.
Okay.
And there is congestion, the mild congestion was present.
Okay. Okay.
And no foreign body also noted in the fornices.
Okay. Okay. So you said your treatment was removal of the filaments and the lubricants,
Yes,
right?
ma'am.
So what
Yes, ma'am.
else can you add in this? You know, when a patient has recurrent filaments.
For ma'am, recurrent filamentary keratitis, we can also add the 5% hypertonic saline as a in a QID dosage, or we can also go for bandage contact lenses to bandage contact lenses. Then
Bandage contact lenses you may put, but if it's a severe dry eye, you would, tend to be very, you may
ma'am,
put if it's a, yeah.
ma'am, for severe dry eye, we can also go for immunomodulators or immunomodulators like cyclosporine and tacrolimus. And if it is a refractory, and we can also go for lifitegrast, 5% eye drops.
About mucolytic agents?
Yes, ma'am. Yes, ma'am. We can also go for N-acetylcysteine mucolytic agent, 5 to 10%. In my patient, I have used 10% N-acetylcysteine as a mucolytic agent prepared from 20% N-acetylcysteine injection, as because this is not commercially available.
So how do you plan to follow up this, and how do you plan to now, see this, and what other treatment are you planning to add? Since you say it's recurrent, right?
This is the first episode for the patient. Yes,
Okay.
ma'am.
Okay. So how frequently are you going to see, and what all are you going to see?
Ma'am, now on day 10th of the follow, patient is having the clear cornea, but I still want to follow up the patient to rule out the severe dry eye. On the subsequent follow up of the 1 month, I'll perform the Shamastate T-BUT test, and accordingly I'll plan the treatment and rule out the other causes of the dry eye and the associated filamentary keratitis. I would
And
like to
how would
evaluate the
you
patient for
right,
systemic
right.
conditions also.
How would you stain also the cornea? Which stains are you going to use?
Ma'am, we can use a fluorescent staining, rose bengal staining, and lissamine staining. But in general practice, we mostly use the fluorescent staining, which is less epithelial toxic and not less sting to the cornea patient.
So do you think rose Bengal staining is also important in this case?
Yes, ma'am. Yes, ma'am. Rose bengal
Why?
stain is basically stain the devitalized epithelium and the devitalized epithelium mucin. mucin-free epithelium. So for knowing the um, uh,
How is the mucin content you may, yeah.
yes, ma'am. Quantification of the mucin can be, matlab, not quantification, but
So
for
are you aware of any kind of a grading with rose Bengal staining?
yes, ma'am. Van Bridge Westelt graining of corneal and conjunctival staining. I have read about it.
So do you think, did you do this in your patient? Because it's easy to
Uh,
do, right?
yes,
On the
ma'am.
slit lamp, yeah. Did you do
Yes,
that?
ma'am. No, ma'am. There is no availability of rose Bengal stain at ROPD, so I
Okay.
have not done it.
So, Mridal, if you
And did you
didn't have
also,
a rose Bengal stain, what other alternative you have to find out the stain positivity of the
stain?
ocular
Correct.
surface?
Lissamine green, ma'am. Lissamine green stain.
So I'm
And
asking, basically, you have only available which is fluorescein in your OPD, right?
Fluorescent, huh?
yes, ma'am.
So that is one of the most commonly used dye and available dye, to be frank.
Yes, ma'am.
So you can do even the grading with that fluorescent stain many of the times. So in my
Okay, ma'am.
practice also, we are doing only with the fluorescent stain. Swati, you do it with fluorescent or rose Bengal?
So I do it with fluorescent, but you have a grading with fluorescent also. So you get appreciably
Yeah.
good amount of information only with fluorescent. So when you mention that, you should always mention the grade,
Okay, ma'am. Yes,
with
ma'am.
fluorescent. Yeah,
Yes, ma'am.
right.
So
How do
which
you measure tear meniscus height? Sorry, Parul. Yeah. How
no,
do
no,
you
you go ahead. Go ahead.
How do you measure tear meniscus height, Manal?
Ma'am, with the help of
Clinically?
slit lamp beam, and with the help of slit lamp beam and on oblique projection, focal illumination, we can measure the tear film height.
Perfect. Yeah. Good.
Parul ma'am, you were asking something?
Yeah. So I was, I forgot. Yeah, I forgot. I think what I was asking.
So,
Something regarding the stain positivity of the surface. Even I think she didn't mention about the superior limbic keratoconjunctivitis. How will you diagnose, Pranal? Because that's one of the most common condition which you see in patients who have
Ma'am,
filaments. So what are the signs which will point towards the diagnosis of SLK?
how do you
signs.
diagnose
It is
SLK?
most uh,
So you have a
in
patient who
SLK
has
there are
filaments. Yeah, go ahead. Yeah.
superior hypertrophied conjunctiva and also the involvement of the superior cornea in the
So mainly you will see filaments and the
the
defects in the upper 1/3 of the
superior
cornea.
cornea.
And
Yes,
what
ma'am.
else
Superior.
would you see in conjunctiva?
This hypertrophic conjunctiva, ma'am.
And
Hypertrophic.
And so the most common thing which actually hypertrophic, probably you may not be able to appreciate every time.
Um, uh, I'm not sure, ma'am.
Stain positivity. So you will see
Yes,
fluorescent stain positive on the
fluorescent
upper bulbar
positivity.
conjunctiva. This may
Yes, ma'am.
be bilateral also. Okay, so most of the time you might see it as bilateral. So that will point towards your diagnosis that this is an SLK. Right?
Yes,
So
ma'am.
what light do you use to look at the stain positivity on the ocular surface?
Sorry, ma'am. I'm not able.
With fluorescent, what all lights can you use on the slit lamp to look at the stain positivity of the ocular surface? So will you use a white
Cobalt.
light? Will you use a
No, ma'am.
Filters.
Cobalt blue filter. It's a blue filter we use to diagnose the stain positivity through with the help of fluorescent lamp. Cobalt blue filter,
any other
ma'am.
filter? Any other filter that you know?
Red free filter, ma'am, which is used to
No, to see the stain positivity of the
stain,
fluorescent, you can use a yellow filter. Nowadays,
yellow,
the slit lamps are equipped with yellow filter.
yellow.
So when you
okay,
want to
ma'am.
look at the conjunctival surface, the yellow filter gives you much better contrast and much better appreciation of your surface lesions than your cobalt free
Yes,
filter.
ma'am.
Suppose this patient recurs, what are you going to do next? In terms of the
Uh,
treatment, forget about the investigations. You know a patient has a dry eye and now the patient has, you have given all the systemic medication, but she still has filaments which are formed. So what is the chronic therapy that you are going to give to this patient to keep
ma'am,
her
for the
going without, developing the filaments? Yeah.
For the recurrent cases, we have many multidisciplinary actions. Like we can use the bandage contact lenses. We can do punctal plugs or punctal cautery to maintain the tear film. We can also go for immunomodulators like cyclosporine, tacrolimus, lifitegrast. We can also for recurrent cases. Uh, preservative-free preservative-free lubrications and ointments at the night time. Ma'am, I'm not
Muted,
able to.
Parul.
Parul ma'am, you are mute.
Oh, sorry. So you will use, obviously preservative-free lubricants, preferably a gel preparation. Use
Yes, ma'am.
these mucolytics. Probably you'll have to keep them for a few months on that. And
Yes, ma'am.
the immunomodulator therapy with topical cyclosporine or with tacrolimus.
Yes, ma'am.
Levetiracetam is a newer molecule. So I think we have
Yes, ma'am.
less experience with that. But
Yes, ma'am.
definitely the conventional therapy is that.
Yes, ma'am.
So did you, and also you check for corneal sensations, right, Mrinal?
Yes, ma'am. Yes, ma'am.
Why it is important to check for corneal sensations?
Ma'am, to rule out the neuropathic keratitis, and it can all to rule out if the corneal sensations are decreased, can give the history of herpes infections or herpes infections can herpes infection and systemic conditions like DM, which decreases the corneal
Any
sensations.
nerve palsy that you think of when you have low
Facial nerve palsy, ma'am.
seventh nerve, right?
Yes, the decreased sensation can lead to decreased blink rate, and exposures can lead to dry eye and will lead to filamentary keratitis.
Yeah, so now we are coming to the end of the
Yeah.
session,
I
and
think she presented very well and she answered very well also.
yes.
Hats off to our mentors,
Yeah.
Charuta
So
and
Charuta and
Amrita.
Amrita, yeah,
Yeah.
both the students, they did very well, and
Yes. And
so
Dr. Satish
congratulations.
also for
Yeah.
your student. Shraddha was really good and for that excellent surgery.
Yeah. So congratulations to Mrunal and Shraddha both. And now I request Dr. Charuta, Dr. Satish, and Dr. Amrita to share their feedback. So Charuta.
Hi, thank you so much for this opportunity for Dr. R.N. Cooper Hospital and Dr. Mronal to present. She has taken the effort to read from textbooks, which many people are not doing nowadays after some prompting, and that has really helped. And I must say that she is our only resident. There's no senior, no junior to her. So she's only resident working right now. So she's getting a good experience, hopefully. And thank you, Swati ma'am and Parul ma'am, for a complete question answer. So she's totally prepared with this keratoplasty. And thank you to MOS for having this. A lot of effort has also been put by Dr. Amrita Ajani, who's the cornea specialist. So she has directly mentored her for this specific case. And it was a wonderful experience and a good preparation for the MS exam also.
Yeah. Thank you, Charuta. Dr. Amrita, are you there?
Yes, ma'am, I'm there. I just really want to thank Mos for this amazing opportunity for postgraduates because they do not get this question answer and viva format otherwise. Some of them directly present in the exams. So this is really nice. And Dr. Swati and Dr. Parul ma'am, both of them gave her insights into everything. So I'm sure she's going to learn a lot from this and go back and read even more and do better in her exams. So I thank you. I really big thanks to everybody for this. Thank you.
Thank you. Satish, are you there? Dr. Satish? Yeah. Satish, you're mute.
Good evening, madam.
Good evening, Satish.
It's a pleasure
Yeah,
to hear
Satish is our
everything, madam.
student.
Thank you, madam.
He's our student. I
Yes,
mean, he
madam. Madam is
was
my teacher.
he
Thank
was
you,
with
madam.
us
Thank
at
you so
Government
much for
Medical
that.
College, Chhatrapati Sambhaji Nagar or Aurangabad. So, Satish, your feedback, please.
Madam, it was a wonderful session, to be very honest. Actually, I am traveling, but madam insisted me, please attend the session. It is really wonderful. And sometimes because of these things, we read. Like teachers, sometimes it's not possible all the time, but these are the few things where it motivates to teachers for the learning purpose. So it's a really good session to attend, madam. Thank you very much.
Thank you, Satish.
Just one more point I want to add in that one thing we couldn't do, that is that keratometry, this thing for about the refraction on consecutive follow. That was a very good point. I personally, on my personal level, I note down that every follow-up I must do the keratometry, so that the post-op refraction that need to be assessed on regular basis. And second point, that because of the visibility of the superior part, we did the surgical P at 7 o'clock. There are two things. I'll take a note, madam. Thank you and thank you very much.
Excellent surgery, Satish.
Thank you.
I would say, yeah.
Yeah, Parul ma'am and Swati ma'am, your feedback, please, and then we'll end the session.
Parul, you go ahead.
Yeah, Parul ma'am.
Yeah, so I think it was really good. This basically primes your students for the exams, and they also start thinking about, in their clinical practice. So when the next case will come, I think probably Mrinal will try to look at the things which we spoke about, how we should do a corneal stain, the staining of the ocular surface, and how would we look at the tear film, and how will we investigate this patient, So I think this is a good teaching for the PG students. And it's really a good program.
Thank you, ma'am. Swati ma'am.
Absolutely, I agree with Parul, because it's a very good platform, Manal. You would realize that speaking in such a forum, you gain a lot of confidence and also to answer the questions, and that takes a lot of fear out of you. When you are actually presenting in the exam, and you have such excellent mentors, it's a very good opportunity that you have. And since you are the only PG and the others, you have so much to learn also. So I
And
think
so
with
much
this
to work
mentorship,
also. She must be
yeah,
working very hard, only
and yeah,
resident.
I know.
Yeah.
And I think this is the first time I'm attending such kind of a session where, you get to ask questions directly from the PGs, and an excellent initiative by Moss, I would say. Yeah, thank you. Thank you
So,
for having me.
Thank you, ma'am. Thank you. So, thank you, Dr. Mrunal and Dr. Shraddha, for your wonderful presentations. Thank you, Dr. Charuta, Dr. Amrita, and Dr. Satish for mentoring the students so well. And a big thank you to Dr. Swati ma'am and Dr. Parul ma'am on behalf of the Maharashtra Ophthalmological Society for this excellent teaching session. So, I thank you all. And now we can end this session. Thank you.
Thank you, Archana, and thank you,
And
everyone.
thank you,
Thank you,
Sunil ji.
everyone. Yeah.
Thank you, Sunil ji, for always supporting us. Thank you.
Thank you.